This is Sophie and Monique, and the talk title is Exhale Breath Analysis for Asthma Detection in Children, Leveraging and Comparing SIFT-MS and GC-ToF-MS. Sophie and Monique are professionals in the Pediatric Pulmonology Department, dedicated to advancing children's health. They use technologies such as GC-ToF-MS and SIFT-MS in their research, and their work involves optimizing sampling and analysis methods, contributing significantly to the field of pediatric pulmonology. They're leading the ADE-M2 study focused on diagnosing asthma in preschool children based on the breath test.
Good afternoon, we are Moniek van Aarle and Sophie Kienhorst, and we work at the Pediatric Pulmonology Department of the Mosaic Kids Children's Hospital in Maastricht, the Netherlands. Today we will present to you in the upcoming 15 to 20 minutes our study on leveraging and comparing SIFT-MS and GC-ToF-MS analysis of exhaled breath in school-aged children with and without asthma. Asthma is the most common chronic condition in childhood with a prevalence of 9.1%. However, a proper diagnosis of asthma remains a challenge and misdiagnosis often occurs. Two population-based studies showed an underdiagnosis of asthma in 37 to almost 62% of all subjects. The European Respiratory Society Task Force only recently developed the first diagnostic algorithm for the diagnosis of asthma in children aged 5 to 16 years. But this algorithm is based on multiple tests and therefore quite challenging in daily practice. On top of that, this algorithm does not really facilitate the ambition of precision medicine, in which the accurate grouping of patients based upon their underlying pathophysiology is pivotal. Here I show you the published algorithm by the ERS task force. All the different diagnostic tests needed are highlighted in orange, and as you can see, there are quite many of them. In search of a simple and reliable diagnostic test, in the past decades, several studies have focused on the diagnosis of asthma or asthma subtypes or the prediction of asthma attacks by analyzing patterns of volatile organic compounds in exhaled breath. And Ibrahim and colleagues published a comprehensive overview of all these studies in the ERG Open Research 2 years ago. And as you can see in the circle diagram on your left, the majority of the studies were cross-sectional, and approximately 2/3 of them used mass spectrometry, primarily GC-MS, to analyze the breath. Unfortunately, the variability in study design across the studies and the lack of external replication hindered the identification of robust breath-VOC multimarker signatures. But one striking observation was the consistent identification of VOCs associated with lipid peroxidation in those patients with asthma associated with clinical biomarkers of type 2 inflammation. The current gold standard for VOC analysis is GC-MS, and the majority of studies on breath analysis use this technique, as showed by Ibrahim in the previous slide. However, selected ion flow tube mass spectrometry, SIFT-MS, has a lot of potential advantages over GC-MS. As you can see on this slide, there is a massive time advantage compared to the analysis with GC-ToF-MS. The SIFT Ultra 200 only needs 5 minutes for a full scan analysis. Besides this full scan analysis, the SIFT-MS also has the possibility to analyze the breath sample in a SIM mode, selected ion monitoring. Depending on the amount of compounds selected, this allows you to scan and quantify within a minute, and also shows you the concentration of the selected compounds directly on the screen. Another advantage of the SIFT-MS is the quick and easy calibration that can be done by non-technical operators, making the SIFT, together with the less frequently needed maintenance, much more user-friendly. The detection limits of the SIFT are quite promising, and it is very interesting to see if it's comparable to GC-MS for breath analysis in healthcare. Here you see a schematic overview of the basic principles of SIFT-MS. In box 1, you see a microwave discharge ion source, where ions are generated by a mixture of laboratory air and water vapor. These ions enter the first quadruple mass filter, where single ion species are selected to act as so-called precursor ions. In the majority of SIFT analysis, H3O+, NO+, and O2+ are used as precursor ions, and these have been chosen because they are known not to react significantly with the major components of air, just oxygen. But they can react with many of the very low-level trace gases. As shown in box 2, the selected precursor ions are injected into a flowing carrier gas, for example helium. At the same time, in box 3, the breath sample enters the flow tube at a known speed, where they meet the precursor ions and may undergo chemical ionization, depending on their chemical properties. This is shown in box 4. The newly formed product ions flow into the mass spectrometer chamber, box 5, which contains a second quadruple mass filter and an electron multiplier detector, which are used to separate the ions by their mass-to-charge ratios and measure the count rates of the ions in the desired MZ range. The majority of studies published on SIFT-MS data used SIFT-MS in the selected ion monitoring mode, where they measure only a single or a couple of compounds. However, some studies attempted to process untargeted full-scan data for pattern-based classifications. This was done, for example, in a recent study on asthma subtypes. Stefanuto and colleagues studied a multimodal combination of GC-ToF-MS and SIFT-MS for asthma phenotyping using exhaled breath. They composed a supervised classification model outcomes using the most significant features using random forest algorithms. The top picture is GC-ToF-MS and the bottom pictures are SIFT-MS. The receiver operating characteristic curves show values of 73% for GC-ToF-MS and 87% for SIFT-MS. The PCA plots depict in both techniques the apparent differentiation between the eosinophilic phenotype and the others.
Previous articles have already demonstrated the potential of SIFT-MS for breath analysis. In our study, we aim to distinguish between asthmatic and healthy school-aged children by analyzing FOX in their exhaled breath. We will utilize the gold standard GC-ToF-MS, use also the SIFT-MS, and we will explore the feasibility of combining both analytical methods. We conducted a cross-sectional study at the Moniek Children's Hospital in Maastricht, the Netherlands, focusing on children aged between 6 and 12. For our asthmatic cohort, we enlisted children in this age group who were under the care of expert pediatric lung clinicians, had undergone lung function assessments, and often had been receiving medication for several years as part of the treatment regimen. Our healthy participants, also aged between 6 and 12, were recruited from various sources, including siblings of an asthmatic patient and a subset from local schools. All participants underwent a breath test using our sampling device. Here's an overview of our sampling procedure. The breath samples were collected in our dedicated research room, where we continuously monitored temperature and humidity, and also took room samples for reference. Notably, a subset of the healthy children recruited from schools was sampled in a controlled room within the school itself. We used a child-friendly sampling device that allowed children to breathe naturally, thanks to our two-way valve system. Additionally, we employed a VOC filter for 3 minutes before attaching the 3-liter Tetler bag. Afterwards, the Tetler bag was transported to the lab and connected to the SIFT instrument, following a brief validation check. It's worth noting that the SIFT instrument utilizes only 60 milliliters of air, with the remainder being captured in a carbon tube. This tube was then stored in the fridge until we were ready to analyze it using the GC-ToF-MS machine. The first crucial step involves normalizing the raw data generated by both instruments. This normalization process ensures the data is consistent and comparable across sources. Following this correction, our data set is randomly split into 2 subsets, a training and a test set. Within the training set, we employ a variable selection process to identify the most pertinent factors that contribute to the classification model. This step is crucial in enhancing the model's accuracy and efficiency. Once our model is fine-tuned in the training set, we move on to the evaluation stage, where we measure sensitivity and specificity. This evaluation is not a one-time affair, but a thorough process that is repeated 1,000 times. This extensive repetition allows us to optimize internal validation, ensuring that our model performs consistently. All the findings from these individual models are then integrated to form our final classification model. In the course of our research, we successfully enrolled more than 100 children, with 51 of them having asthma and 68 falling in the healthy category. On average, our study population was 9 years old, and we observed a predominant male representation within the group of children with asthma. Furthermore, the variations between the asthmatic and healthy groups are illustrated in the table. These differences primarily revolve around factors such as atopic diseases and a family history of asthma and other allergic conditions. Upon closer examination of our asthmatic population, it becomes evident that we are dealing with a group displaying mild to moderate asthma symptoms. This can be clearly seen in the table, where more than 88% of the asthmatic children are using inhaled corticosteroids, and 40% have experienced an exacerbation in the past 3 months. At the time of testing, it's noteworthy that the asthma of most children was either well or partly controlled, as indicated by the GINA score just before the breath test. We started with analyzing the data from our GC-MS and SIFT-MS techniques separately. As we progressed through the procedures we mentioned earlier, the result was the creation of these PCA plots. In both plots, the healthy participants are the blue dots. These visual representations reveal some noticeable patterns, suggesting the possibility of developing a model that relies on the most discriminative factors to distinguish asthma patients from healthy controls. As we closely examined the PCA plot, we could see there is some grouping within the asthmatic patients. A possible explanation we considered was disease activity. One group could be the well-controlled asthmatics, exhibiting similarity to the healthy participants, while the other group could experience partial or poor asthma control. However, when we tested this hypothesis, we found no evidence of a distinct group formation based on their GINA score. Another crucial factor to consider is the usage of inhaled corticosteroids, ICS, which may impact the composition of the breath sample. As part of our study, we inquired whether participants had refrained from using their inhaler within the 3 hours preceding the breath test. However, when attempting a subgroup analysis between the daily ICS users and the non-users, we encountered a limitation. The percentage of non-users within the asthmatic group was insufficient for a robust analysis. For the final GC-ToF-MS based model, we selected 17 variables resulting in a discriminatory model with an area under the curve of 0.78, boosting a sensitivity of 76% and a specificity of 72%. In the case of SIFT-MS data, the final model was based on 47 selected variables, yielding an area under the curve of 0.72, with both sensitivity and specificity at 70%. Notably, these models incorporated distinct input variables, since GC and SIFT-MS technologies capture different sets of FOX, which led us to consider the potential advantages of combining both methods while constructing a discriminatory model. Through this combining approach, we generated a distinct PCA plot. In the first three principal components, a clear group formation emerged between the breath samples of healthy participants and asthmatics. By applying the same data analysis steps as before, we enhanced the RSC curve, resulting in an impressive area under the curve of 0.94, with a sensitivity and a specificity reaching 78%. In summary, the table presented below provides an overview of the results obtained from the GC-ToF-MS, the SIFT-MS, and the combined application of both techniques. Our study boasts a substantial and well-monitored study population, particularly in terms of asthmatic patient diagnosis. This has yielded a robust and diverse dataset for our model. However, it's important to note that the patients in our study are mostly well controlled and have been using ICS medication for an extended period. This is in contrast with the possible timeline when a doctor would order a breath test in the future. The patient then will have complaints, visit the doctor and perform the breath test, and then receive the treatment. Our participant selection came afterwards, so there could be a difference. Our sampling procedure was standardized, covering aspects such as bag handling, room conditions, temperature and humidity, and the timing of the bag filling and the breath collection before analysis. While most patients were tested in the hospital, a subset of healthy patients underwent testing in a school setting. However, we confirmed that this difference did not impact the results. As of now, the study's results have not yet been published. We are currently in the process of identifying specific FOX. We hope this will provide future insights into the reasons behind the observed benefits of combining GC-MS and SIFT-MS data. We should seriously consider the potential of incorporating breath tests into the clinical practice. In our specific study, SIFT-MS demonstrated distinct advantages for clinical applications over the GC-ToF-MS. SIFT-MS is notably more user-friendly as well as clinician-friendly, both in terms of device handling and data analysis. It offers the convenience of direct sampling, the SIM mode, providing rapid results within a minute, displaying parts per billion level of selected compounds. Additionally, it proves to be more cost-effective with lower per sample costs and reduced maintenance requirements. Nevertheless, the integration of SIFT-MS into the daily clinical practice still faces challenges, primarily due to the initial high equipment costs and the need for stable sample storage and subsequent analysis. While we utilize sampling bags for our study, the potential for direct sampling holds promise for future implementation. In conclusion, our study demonstrates that SIFT-MS is a comparable alternative to GC-ToF-MS for diagnosing asthma in school-aged children. Another important conclusion is that SIFT-MS exhibits promising potential for practical clinical implementation due to its user-friendliness and cost-effectiveness. Thank you for your attention.
So we've got time for some questions. I was going to kick us off with the first one. So you mentioned in the model there was 17 VOCs. in the model. Have any of them been identified yet? I know you said you're trying to find out what they are, but it'd be interesting to see if you have a sense of even the class of compounds so you could relate it back to the biology.
No, sadly, I have to disappoint you. We are at the moment still at the start of identifying. What we did do was already check some of the variables that we got from GC-MS and compare them with the SIFT-MS. Those are indeed different variables. We already know, but we don't know exactly which ones they are. But we will definitely find that out, and then yeah, our article will be published later. Yeah.
Brilliant, thank you. I was interested in the points that were brought up around usability of the SIFT. One of the questions here is, in terms of user training and skill requirements, how easy is it for professionals to learn and operate the SIFT? Are there any specialized skills or expertise needed to maximize the performance of this technology?
Yeah, well, I can tell about the experience I had with the machine. So for GC-ToF-MS, I won't be able to do anything, but for me as a doctor, we learned how to operate the SIFT-MS. It was really user-friendly, and we also had the option where you can perform the sim mode scan. So you have a direct scan, within a couple minutes, you have the results already. So if you already know what you're looking for, then it's even more easy. But for me now, at the moment, yeah, it's very simple to attach it, press the right buttons, do the validation checks, and keep getting consistent results. So that's very nice from the SIFT-MS. Yeah.
Great. Next question's related. So what are the key challenges or limitations that an organization might face if they were adopting SIFT-MS, and how could they be overcome? It sounds easy to use. Is there any kind of limitations you would say if it was deployed in clinic?
Yeah, well, still it's still a big machine, and it's still pretty expensive to buy at the beginning. And that comes with the second thing is we still need to use tether bags to transport the breath to the machine. And especially when we work with children, I already know that there are some mouthpieces you can directly attach to the SIFT, but then you have to give a good demonstration and how they need to perform it. And we use it for children already from 2 to 12 years old. So it's a big variation. So I think when coming back to your question, I think some challenges are still that the breath sampling still needs to be done with bags. And maybe in the future, we can make some kind of mask that can attach easy for children as well to utilize the SIFT fully.
Brilliant, thank you. Next question here. So as you continue analyzing data in the study, were you able to link specific VOCs and exhaled breath to categorize asthma types such as neutrophilic or eosinophilic driven inflammation? I know you said you haven't identified the compounds, but I suppose, do you have those different types of asthma in this study?
Yeah, that's a good question. We all the children we measured, we also take a short amnestic history, and we checked if their asthmatic would be related with what kind of triggers they have. So, and we also have some blood samples of the children. We didn't take them, but we can get them from their history. So we are still, we're definitely going to look into it if we can do a discrimination between asthmatic types. While also considering that we only have, or not only, we already have 60 asthmatic patients, but yeah, maybe it's a bit kind of a small group if we already divide them, but we definitely are going to look for it. Yeah.
Brilliant.
And to
oh, sorry, go ahead.
Comment.
Go ahead.
Yes,
yep.
I'm really sorry, my video doesn't work. To comment on that, unfortunately, we do not have the sputum or bronchoalveolar lavages in which we actually check for eosinophilic or other biomarkers. So unfortunately, we won't be really able to answer to that question in this small subgroup of children.
Got it. Thank you. And it seems one of the advantages of SIFT is that real-time analysis. I'm wondering, in asthma, is that a key driver, or do you think it would be okay if you're able to collect a sample in a clinical setting for lab-based analysis, or do you think there's an advantage to having the real-time readout?
I can answer. I think it depends for what you want to use the breath test for. In this case, we try to make sure if we could diagnose it. And if you want to diagnose it, I don't think it has to be real time, so you can like collect your breath and like analyze it later. But I think it makes it easier and quicker if you do the direct sampling. If you have a machine, and then patients would come to your specific hospital where you have the machine, and then directly can use it.
And so far, we have only used an untargeted approach to the data. So we did all the tests in full scan spectra. If we manage to deduct a very small subset of MZ ratios that seem to be most discriminative, it will be very easy for children just to perform a one breath within the SIFT, so that we can analyze it within seconds. But we are really not there yet. But in that case, you could bring the child to the machine. However, the machine is quite expensive. So for implementation in like general practitioner practices, they won't be able to pay for a machine per practice. So anyhow, I think it will have to be based in a laboratory or in a big health center, and children will need to come there to perform the tests.
And in that situation, do you think you might have instruments deployed in a larger center, but you could have, in a primary care setting, samples being collected and brought back to that center then? So a bit of a mixed model of real-time plus offline?
Yes, I think that will be something that will work too. And the downside of the SIFT-MS is that it's not like with e-notices, it's very easy to use and to implement and to buy for a general practitioner. But the really advantage of SIFT-MS is that you are still able to give a putative identification of the VOX, and that you can use it as well for research better, and to define underlying pathophysiologic mechanisms. So that's why it's more feasible than GC-ToF-MS or GC-MS. But again, an e-notice application is much more easy to use in the daily clinical practice.
I was wondering as well if you could comment on the application around selection of therapies, especially when you think about some of the biologics where you have responders, non-responders for those very expensive drugs. I wonder if you could comment on the potential use of breath and VOCs there.
Yes, at this moment we are performing a very large multi-center study on prediction of asthma in young children, age 2 to 6. And we know that for that subgroup of patients, very little personalized medicine is being applied at this moment, because it's very difficult to use non-invasive measures to understand what the children are suffering from. And we really hope from that big data set that we will be able to identify specific treatable traits, and that you can indeed develop other types of medicine for that. But within this group of established asthma patients that we had here, it's too small, and we have too little other information about that group, unfortunately. It was really used just to check whether SIFT-MS is not inferior to GC-ToF-MS.
Fantastic. Well, thanks again both for the presentation and attending for the questions. We really appreciate it. Thanks a lot.
Yeah.